Good morning, everyone. The topic of my seminar is Neurobiology of Depression, and my moderator is Dr. Shobit Garg, sir. So, this is an overview of the topics that we will go through today. It is a very important topic in view of exams also. So, first of all, we will discuss about genetic factors, then neurotransmitters, then neuroanatomical factors, neuroendocrine factors, neurophysiological factors, immunological factors, and connectomics in depression. So this is an overview of what we are going to discuss in genetic factors. First of all, we will discuss about epidemiological studies, then the chromosomal regions, and the genes implicated in neurobiology of depression. So genetic epidemiological studies are the studies which give information about the familial and genetic nature of the illness by examining the rates of the illness in the relatives. So according to the genetic epidemiological studies, family studies, as compared to the 1% in general population risk, there is 2 to 3 times higher risk in first degree relatives of the major depression program. So, what is the risk of mood disorder in a child? If one parent has history of depression, then the risk is increased to 20 to 25%. But if both parents have depression, then it increases to 100%, almost double. So, this suggests that mood disorders are familiar, but does the only genetic factors play an important role, or environmental factors also play a role? So the debate is that it is whether nature versus nurture. So the twin studies suggest that the concordance rate in monozygotic twins, it is 2 to 4 fold higher than the dizygotic twin. That is, it is 70 to 80% increase rates, but interestingly, it is not 100%. So environmental factors does play an important role along with the familial factors. So these are few traits which are associated with higher heritability, like early age at the onset of illness, recurrency, and comorbid alcohol use. Temperament also plays a role. The predisposition to temperament appears to be partly heritable, in such as high levels of harm avoidance, neuroticism, and low levels of novelty seeking. So these are little. Yes. So these are the chromosomal regions for major depression, which have been reported for recurrent early onset form of illness. These are 2q, 3q, 12, 15, and 18q. Now we will discuss about the genes implicated in the neurobiology of depression. The most important gene is the serotonin transporter gene, that is SLC6A4 gene, and it is the most studied gene in the neuropsychiatric disorders. So it is present on the chromosome number 17, mediates the uptake of serotonin, modulates synaptic serotonin levels, and it is also the site of action for the SSRIs. So a promoter, that is the 5-HTT-LPR promoter gene, contains a repeat region, and there are two major alleles. One is short form and other is long form. So if the short form is present, it expresses less serotonin transporter mRNA protein, and it shows less response to SSRIs. So again, we can see the presence of this short form of allele along with the negative life event. There is a stronger correlation with the risk of depression, which suggests that uh, environmental factors also play a role and familial factors also play an important role. These are some other genes implicated in the neurobiology of depression: BDNF gene, FKBP, dopamine receptor gene, GRIK4, and HTR2A receptor gene. So these are the points to be remembered in the genetic factors of neurobiology of depression. There is 2 to 3 fold higher risk in first degree relatives of major depression programs. Mood disorders are familiar, but environmental factors also play an important role. There are certain traits, temperaments, and chromosomal regions which are associated with higher heritability. And the most important candidate gene implicated is the SLC6A4 gene. Now we will discuss about the neurotransmitters. In this, we will discuss about what is pharmacological bridge, what is the monoamine hypothesis, and also there are other neurotransmitters implicated in neurobiology of depression, not just the monoamine neurotransmitter. And there are other second messengers and intracellular cascades as well. So in 1950s, a drug named as reserpine, antihypertensive drug, they saw that sometimes it induces depression in few patients by inhibiting the release of the monoamine neurotransmitters. On the other hand, the TCAs and MAO inhibitors increase neurotransmitters at the synapse. So, this type of thinking is known as the pharmacological bridge, where we try to deduce the neurotransmitter pathology with the help of the mechanism of action of the drug. And similar kind of thinking was used in schizophrenia while observing the role of the dopamine in schizophrenia. So, what is the monoamine hypothesis suggests? It suggests that there is decrease in serotonin, norepinephrine, and dopamine as well. But it was postulated a long time ago. Now it is considered that there are also other factors which come into play, like neural circuits, neuromodulatory mechanisms, second messenger system, neurokines, excitatory amino acids as well, and gene transcription factors as well. So there are a lot of complexities involved. So first of all, we will discuss about the norepinephrine. The cell bodies are of norepinephrine are present in the locus coeruleus and lateral tegmental area. It has a very important role in initiating and maintaining limbic and cortical arousal and modulation of other neuronal systems as well. So the norepinephrine project rostrally to the hypothalamus, basal ganglia, limbic system, and cerebral cortex. So there are two main projections. One is to the amygdala hippocampus, and other is to the medial forebrain bundle to the anterior cortical structures. Amygdala and hippocampal projection plays an important role in emotional memory and behavioral sensitization to the stress. So if it gets activated for a very prolonged time, it can lead to the learned helplessness. On the other hand, if there is decreased transmission in the medial forebrain bundle, then it can lead to the anergia, anhedonia, and decreased libido, which is seen in the patients of depression. So, uh, also, there is evidence of role of norepinephrine in depression from various findings, and the findings suggest that antidepressant response is correlated with downregulation or decreased sensitivity of beta adrenergic receptors. So, this indirectly tells us the role of norepinephrine in the depression. Next neurotransmitter we are going to discuss is the serotonin, which projects from the dorsal retinal nucleus, which is present in the brainstem, to various other structures like cerebral cortex, basal ganglia, thalamus, hypothalamus, hippocampus, and septum. So serotonin has become the neurotransmitter most commonly associated with depression, and many antidepressants act on this neurotransmitter receptors as well. So these are few roles of normal roles of serotonin in human being. It regulates sleep, appetite, body temperature, inhibits aggressive behavior, regulates circadian rhythm, and facilitates goal-directed behaviors. So, uh, as we have studied that there is a very important gene SLCA64. So it is partly serotonin transmission is partly under genetic control. We have studied earlier. So, life stress associated with genetic inheritance can lead to the risk of depression. Serotonin tone also shows seasonal fluctuation, and as we know, depression also shows seasonal fluctuation. So, in acute stress, there is increase in serotonin, but if the stress is chronic, it will lead to the serotonin decrease, which indirectly will increase the 5-HT1A autoreceptors and decrease transmission of the serotonin. So, depletion of serotonin can precipitate depression. In some patients with suicidal impulses, it has been seen that CSF concentration of serotonin metabolites was decreased and serotonin uptake sites on the platelets was also decreased. Next neurotransmitter we are going to discuss is the dopamine. We know the mesolimbic pathway about the mesolimbic pathway and mesocortical pathway, and we also know the role it plays. So, when the dopamine activities decreases, it leads to cognitive motor disturbances. And in depression as well, there is decrease in dopamine activity. So we know that dopamine levels are inversely correlated with the brain cerebral activity. So drugs which decrease dopamine like reserpine or disorders like Parkinson's disease may cause depression. And on the other hand, drugs which increase dopamine like tyrosine, amphetamine, bupropion decreases the symptom of depression. So the main point is not only serotonin, norepinephrine, or dopamine is responsible, but other neurotransmitters like acetylcholine, which has an inverse relation with monoamine system, is also implicated in the neurobiology of the depression. So, like GABA. GABA has inhibitory effect on ascending monoamine pathways, and it has been seen that in patients of depression, there is decrease in the GABA levels in plasma CSF brain levels. Glutamate also plays an important role in the neurobiology of depression. Uh, Binds two sites associated with NMDA receptor. So there has been an emerging evidence that drugs that antagonize NMDA receptors, like ketamine, have also an antidepressant effects, and it shows a rapid response. Uh, as I have discussed earlier, that not only the neurotransmitters, but also the second messenger systems and intracellular cascades play an important role. So this is a neurotransmitter which gets attached to the postsynaptic receptors. And with this neurotransmitter gets attached to the receptor and interact with the intracellular environment through the G protein. So these G protein connects with the intracellular enzymes like adenylate cyclase, phospholipase C, and phosphodiesterase, which regulates two important functions: regulation of utilization of energy and formation of the second messenger. So, what are the second messengers? These are cyclic nucleotides, phosphatidyl inositol, and calcium calmodulin. It plays an important role in the regulatory function of neuron ion channels, neurotransmitter synthesis, as well as release and regulate protein kinase activity. So this shows that second messengers are also implicated in the neurobiology of the depression. So what are the points to be remembered? That relationship of neurotransmitters is not that simple. Other than monoamine neurotransmitter, there are other neurotransmitters like GABA as well, acetylcholine as well, which are implicated in depression. And second messengers and intracellular cascades also play an important role. Now we will discuss about the neuroanatomical factors. So the key regions which are implicated are the prefrontal cortex, anterior cingulate cortex, hippocampus, and amygdala, which form the limbic system. So the anterior cingulate cortex makes a connection with the emotional limbic system as well as with the dorsolateral prefrontal cortex for the cognitive functions as well. So prefrontal cortex has two parts, medial and dorsolateral prefrontal cortex. So the medial PFC along with posterior cingulate hippocampus forms a default mode network, which is active during resting wakefulness, self-referential thinking, daydreaming. So in depression, there is hyperactivity in the default mode network. On the other hand, cognitive control network, which has the component of DLPFC and anterior cingulate cortex, is active in suppression of negative symptoms. So it suppresses negative symptoms. So in depression, it is seen there is decrease in connectivity of the cognitive control network. So these points will be further supported by the evidence which we found on the brain imaging. So anterior cingulate cortex has also two subdivisions: affective subdivision and cognitive subdivisions. So it also plays a role. Hippocampus and amygdala also play a, are the key regions involved in the neuroanatomy of the depression. So these are the brain imaging findings. Structural findings on MRI suggest that there are abnormal hyperintensities in the subcortical regions. Other findings also suggest ventricular enlargement, cortical atrophy, sulcal white. And it has been seen that there is decrease in the hippocampal volume, medial orbital cortex, and anterior cingulate cortex. And if a decrease in the hippocampal volume is associated with the illness chronicity. And there is also enlargement of pituitary and adrenal gland. So these functional findings supported our previous point. On functional MRI, it showed that there is increase in the activity of DMN and there is decrease in the connectivity in the cognitive control network. On PET, it was PET scan. It was seen that there is decrease in the anterior brain metabolism and decrease in the cerebral blood flow, glucose metabolism in DLPFC. So, what are the points to be remembered in neuroanatomical factors? That key regions involved are PFC, ACC, hippocampus, and amygdala. And MRI findings suggest abnormal hyperintensities and enlargements as well as reduction in the volumes of these key regions. And on functional MRI, there is increase in the activity of default mode network and decrease in the activity of cognitive control network. And on PET scan, there is decreased anterior brain metabolism in cerebral blood flow. Now we'll discuss about the neuroendocrine factors. We will discuss about hypothalamo-pituitary adrenal activity, hypothalamo-pituitary thyroid axis activity, growth hormones, and prolactin. So it is a hallmark of mammalian stress response, and it is one of the clearest links between depression and the biology of the chronic stress. So what is the normal HPA axis system? From the hypothalamus, corticotrophin releasing hormone is secreted, which stimulates the anterior pituitary. Then the ACTH is secreted, which stimulates the adrenal cortex, which leads to the formation of cortisol. And cortisol has an direct negative feedback control over the ACTH as well as the corticotropin releasing hormone. This is the normal HP axis. But in depression, this HP axis is elevated and there is hypercortisolemia. So, hypercortisolemia and depression suggest one of the following central disturbances. Either there is inhibitory serotonin tone, or there is decrease in the feedback inhibition from hippocampus, or there is increase in the drive from norepinephrine, acetylcholine, and corticotropin releasing hormone. So, how can we document the hypercortisolemia? These are the few methods which we can use. Uh, so, these are some tests of integrity of feedback inhibitors. Most important is the dexamethasone suppression test. As we all know, dexamethasone is a very potent glucocorticoid. It is given at night, 0.5 to 2 mg. Normal response will be there will be decrease in all these CRH, ACTH, and cortical surge. But in depression, due to hyperactivity of the HPA axis, there is no suppression of this cortisol surge. But this test is not diagnostic test. It is neither sensitive, it is not specific, because it can be normal in patients with depression and it can be abnormal in other conditions as well, like Cushing syndrome, mania, schizophrenia, and depression. So patients with increased what are the implications? That patients with increased HP activity are less responsive to psychotherapy and there is greater need for pharmacotherapy or electroconvulsive therapy in such patients. If patient continue to have persistent increase in HP axis despite the treatment, there are higher chances of relapse. So interventions that suppress the HPA axis, like dexamethasone, cortisol synthesis inhibitor, like ketoconazole, are also sometimes used in the treatment of refractory depression. So what are the future implications? That in future, there can be central CRH receptor direct antagonists. Another test is the CRH stimulation test. In this also we will give CRH. There should be increase in ACTH or cortisol, but in depression there is a blunted ACTH response due to downregulation of CRH receptors in the pituitary gland. Now we'll discuss about the hypothalamo-pituitary thyroid axis. It has been seen that 5 to 10% patients who were evaluated for depression previously had undetected hypothyroidism. This diagram depicts the hypothalamo-pituitary thyroid axis and how the thyroxine is formed. So another test is thyroid releasing hormone challenge test. If you normally administer TRS, there should be increase in TSH, but due to the blunted response in depression, 20 to 30% patients shows this TSH blunted response and may result from pituitary down regulation due to increased TRH level. So what are the therapeutic implications? Increased risk of relapse despite antidepressant treatment in such patients. Also, blunted TSH response to TRH does not normalize with effective treatment, and therapeutic benefits of inductive therapy with T3 or other thyroid hormone may be mediated by decreasing this response. As we all know, growth hormone has a pulsatile secretion and follow 24-hour circadian rhythm, and secretory surge occurs during first few hours of the sleep. So, growth hormone is released from anterior pituitary, and release is stimulated by norepinephrine dopamine, while hypothalamus also has a inhibitory control by CRH and somatostatin. So most consistent finding is that there is blunted growth hormone response in patients with depression. Similarly, there is also blunted prolactin response to serotonin agonist in patients with depression. So what are the points to be remembered? That depression is a state of, there is a state of hypercortisolemia in depression. Test of integrity of feedback inhibitions in HPXs, you can be used like DST and CST, but DST is not is not used as a diagnostic tool. Thyroid axis activity is also affected, which can be demonstrated by TRH challenge test, and growth hormone and prolactin also play an important role. So now we'll discuss about the neurophysiological factors. First, we will discuss about the sleep neurophysiology. In depression, there is a premature loss of deep sleep, that is slow wave sleep, and increase in the nocturnal arousal. So, which leads to increased nocturnal awakening, decreased total sleep time, phasic REM sleep, and poor body temperature increase. So, with increase in REM drive along with the decrease in the slow wave sleep, there is a reduced REM sleep latency. So, significant reduction in the first period of REM and REM sleep, that is reduced REM sleep latency. So, shortened REM latency may serve as a trait marker for depression, and it is also found in other disorders like dysthymia, borderline personality. So, these abnormalities can be partly hereditary. So EEG is not used as a diagnostic tool, but it has been seen that patients with abnormal sleep profile are less responsive to psychotherapy and may benefit more from the pharmacotherapy, and there is greater risk of relapse or recurrences in such patients. Another theory is neuronal hyperexcitability. Regarding the neurophysiology of depression, hypothesis suggests that during mood disorder episode, there is movement of excess sodium into the neuron, which lead to the unstable state of neurophysiological excitability. And during the recovery phase, it has been seen that there is redistribution toward the pre and less electrolyte balance across the neuronal membrane, suggesting that there is neuronal hyperexcitability in the mood disorders. So intraneuronal sodium leakage is postulated both in depression as well as mania. It points that electrophysiological disturbance and in depression and mania is in same direction. But this violates the symptomatological opposition. But it can account for the mixed states seen in the mania together with the mania and depression. So we can also correlate with the mechanism of action of lithium. Lithium is known to replace intracellular sodium and hyperpolarized neuronal membrane, thus decreasing the neuronal hyperexcitability, suggesting that this hypothesis may be correct. So what are the points to be remembered in neurophysiological factors? That there is a premature loss of deep sleep and increase in nocturnal arousal, and there is reduced REM latency time. Now, this is the second last topic. Now we'll discuss about the neuroimmunological factors. Types of what are the types of immune responses? What is the effect of depression on immune responses? Role of antidepressant and immune system, and can anti-inflammatory drugs be used as antidepressants? So there are two types of immune responses: acquired and innate. In acquired innate, there it consists the components are lymphocytes, lymphokine-derived cytokines, antibodies, and memory cell. So all these are decreased in the depression. There is decrease in lymphocyte. Ratio of CD4 to CD8 cells is also decreased. So overall, there is an immunosuppressive changes which occur, and these changes are more seen in more severe, older, hospitalized, or melancholic depression patients. So it appears to be associated with clinical severity, hypercortisolism, and immune dysfunction. So another response is the immune response, the innate response. The components of innate responses: phagocytes, macrophages, derived cytokines, the interleukin 1, 6, TNF alpha, interferon gamma, and acute phase reactant. So what is the effect on innate immune response in depression? There is increase in pro-inflammatory cytokines, increase in acute phase reactants, chemokines, and soluble adhesion molecules. So it suggests that depression can be a pro-inflammatory state. There is also alteration in the metabolism of neurotransmitters like serotonin, dopamine. So second point is there is immune activation in depression may be involved in pathophysiological changes seen in depression, leading to bone loss, insulin resistance, increased body temperature, hippocampal volume. This is an important point. Inflammation has a very important role, and inflammatory process is increased in depression. Also, uh, these disorders may lead to depression, and depression may have a very negative impact on these disorders, and vice versa. We see that depressive patient may later on develop some of these medically inflammatory conditions. Factors such as early life adversities we have discussed earlier increase the innate immune responses in the depression, and increased BMI also increases inflammatory markers such as interleukin 6. So what is the role of antidepressants in immune system? So in certain chronic cytokine exposure conditions such as malignant melanoma, in which we use interferon alpha, chronic exposure to these cytokines may also develop depression. So it is telling us that inflammation may lead to depression, And it is seen that this depression may be decreased by the antidepressant, even if we give it prophylactically. So this shows the association of the antidepressant. Antidepressants decrease the pro-inflammatory cytokine, increase intracellular second messengers, increase anti-inflammatory cytokines such as interleukin-10. It has been seen that ECTs and exercise also has an anti-inflammatory effect, suggesting that depression may be caused by inflammatory changes. So, can the anti-inflammatory drugs used as antidepressant uh, NSAIDs as augmenting agents in major depressive disorder has weak association. But more specific anti-inflammatory drugs like cytokine antagonists such as infliximab have some antidepressant potential, but more in inflammatory condition. Other than inflammatory condition, they have not have that much of effect as antidepressant drug. In patients with high sensitivity CRP, there may be correlated with increased antidepressant response to the infliximab. So, is depression an anti-inflammatory disease? Data suggests that there is increased inflammation occur only a subgroup of patients, especially with those with the early life adverse event or with obesity. Uh, this is the final subtopic, connectomics and depression. Depressed patients often have cognitive and behavioral deficits, as we have discussed earlier, which is characterized by heterogeneous symptoms. The neurobiological mechanism of which almost remains unknown. So there are different treatment types for depression. However, the response and remission rates remain low, and neurobiological basis of treatment effects is still unclear. So functional connectomics has provided useful tools to characterize depression as a brain network disorder and guide treatment decision making. Recent work suggests that multidimensional depression symptoms are linked with abnormalities of the function connectivity and network organization in different brain networks. So each treatment type tends to improve specific symptoms by modulating specific network, suggesting a need for the combined treatment. So there was one study in which altered brain activity in unipolar depression and was unveiled during using connectomics. They examined whether study-derived coordinates might delineate a dysfunctional brain network in unipolar depression rather than isolated neuroanatomical foci. Utilizing data from 57 studies and 99 individual neuroimaging task-based experiments, testing either emotional or cognitive processing. Further, they assessed clinical relevance by computing optimal network-based personalized targets in 26 individuals who previously received TMS for unipolar depression. Although coordinates were neuroanatomically heterogeneous, they localized to highly robust distributed brain networks. So, what is the take-home message? Mood disorders are familiar, but environmental factors also play important role. Uh, One of the most important gene implicated is SLC6A4 gene. Other neurotransmitters, other than monoamine neurotransmitters or secondary messengers and intracellular cascades, are also implicated in depression. Key regions involved in the neuroanatomy of depression are the prefrontal cortex, anterior cingulate cortex, hippocampus, amygdala. Structure and function imaging support the changes in these regions. Uh, in depression, there is elevated HPA axis, that is hypercortisolemia. Thyroid axis dysfunction is also there, and blunted growth hormone and prolactin response is also seen. Sleep neurophysiology, we have to remember that there is premature loss of deep sleep, that is slow wave sleep, and increase in nocturnal arousal and reduction in REM latency. Overall, in immune responses, it is the immunosuppressive changes that occur, and depression is a pro-inflammatory state, but inflammatory changes occurs only in a subgroup of the patient. These are my examples.
Open for questions and clarification. A very important area for the MBBS interns also because a lot of MCQs are been answered in this presentation. A long question which can be a nightmare during exams by hearting everything. So, and also a Viva question if you get a long case uh, of depression, many things are at risk. So please, your contributions. Anything which you have not understood,
Pharmacological bridges, where we try to deduce the mechanism or pathology of the neurotransmitter with the help of the action of the mechanism of action of the drug. Like in 1950, preserpine was used as antihypertensive, and it was seen that it was reducing depression in few patients. So the mechanism of action of the induction of depression was that it inhibits the release of the monoamine neurotransmitter. But on the other hand, the TCAs and MAO inhibitors, other antidepressants were being used, and their mechanism of action was that it was increasing neurotransmitters at the synapse. So this type of uh, uh, hypothesis is pharmacological bridge, and monoamine hypothesis was also postulated.
Basically, by serendipity, maybe which has been discovered by serendipity, then they are saying, ki, okay, we are very clear with the mechanism of action of the molecule. It is helping in one disorder, so maybe the disorder is also having the same mechanism of the pathophysiology. We didn't address those jackknife, jackstat. We didn't address NFK. We could not address those because of time constraints.
Yes, sir.
Yeah. Finally, on that slide, beautifully he has mentioned. So there is a very important slide. ACC has a connection with the limbic system. So this becomes an hyperactive pathway, and then ACC's connection with the PFC, this becomes an hyperactive circuit. So connectomics, that is what actually you have mentioned, connectomics neurons. So now, recently what they did in a very I would say, very exciting trial. They saw from fMRI, they saw that in depressed patients, dynamically, what was a region of DLPFC which was least connected to ACC. So they measured it in the fMRI. Every patient had a different regional point, and then they stimulated that region by EMS. And they could found very exciting results in refractory depression. This is off late. So this is how they are now extrapolating this knowledge into in clinical scenario, deriving benefits. This becomes a very important. Dr. Mishra? Yes. Correct points.
Connectomes, I have mentioned in these slides that there is not only a foci or single system which is involved in depression. They are trying to mention that there are other networks as well, that like default mode network, cognitive control network, as I mentioned. So
Second last slide, if you do, I think that's
yes, this one.
next. Next. We want to know what do you mean by correctomes?
Describe it.
Genomes,
How can you
epigenomes, uh, then they're saying metabolomes, correctomes. So it's a way of addressing
like
a cluster of
this
the
one?
regions subsequently involved in the pathology and having a genetic uh, underpinnings. So any defined brain network, you can call it as correctomics. Those are ways to determine what areas are. What is proband? He mentioned in the first slide, proband. He mentioned proband.
Yes, sir.
Huh? So proband is a disease population, any disease population in context of genetic study. So we'll not use probands in the text of maybe clinically. Okay, that proband is there. But when you do a genetic study, it says the same disease population is a proband, individual as a proband.
Earlier on, in that specific brain area, what it is there that they found all the data. And so what they're finding is that it is heterogeneous. That's not one data. But it is not that the findings cannot have any meaning. It is although they're heterogeneous, but they are localized to highly robust distributed brain networks. Now instead of areas, we are now focusing on brain networks. In that also you can find out which networks if you stimulate or if you depress, you can have meaningful interventions. So RTMS is based on that only.
He said DMN, he talked about cognitive executive network, CEN. So those are very important. We need to now be more aware of these things because I was reading something 2 days before. There is a biomarker which has been launched in France, which will differentiate unipolar depression from bipolar depression. And to actually, it targets those specific RNAs and will give you a quantitative assay, which you can say, ki, okay, this patient. Though they are saying that it is not insurance covered, but now there's a started to come. So maybe it becomes the exciting time next 10, 20 years will have biomarker. The psychiatrist only field which is under. Hmm. Amita? Uh,
Well, we can use those agents as an augmenting agent, but the main cause of the depression will be thyroid dysfunction in such patients. As I mentioned, there are 5 to 10% patients which are completely suffering from thyroid dysfunction. Then they go into depression. So
there are a few things which need to be very clear. Why we do thyroid levels in someone who comes to us with depression or cognitive deficit? Because hypothyroidism or thyroid dysfunction, thyroid diseases mimics, like lethargy, slowness, concentration deficits, excessive sleep, loss of energy, uh, leading to loss of interest. So these symptoms are overlapping with what we find in depression or cognitive loss. So that is why we are screening for thyroid disorders in most of the population. So if we find, okay, TSH is more than 10 or also between 5 and 10, I'm talking about subclinical picture. So if we find that there is a deficit and there is a considerable psychiatric load, we need to correct that dysfunction. So this is one aspect. Another aspect is thyroid in psychiatric disorders, there is dysregulation of thyroid axis. But now studies have found that if you try to regulate those thyroid axis disturbances, which are subtle, then it doesn't provide much benefit. And the side effects of supplementation generally are more than the benefits which we achieve. So, like very simple example is TSH diurnal variation. It gets blunted in depression. So, if we try to correct that, doesn't help. So that is why treating thyroid, subtle thyroid dysfunctions secondary to psychiatric disorders have never helped. Now, third aspect is when we talk about refractory depression. So the whole concept of study claim, they said that T3 augmentation. So that's a totally different gamut. Specific subsets of refractory depression patients, there is a central hypothyroid where T3, T4 is not converted to T3 because of deiodinase dysfunctions. So what happens is when you, so there is no T3, so the monoamines are not made, patient actually have an phenotype of depression. So those actually patients have found to have central hypothyroid, or they are actually athyroid also in many senses. So their T3 would help, but T3 is barely available. T4 doesn't have any role there also. So this is the whole understanding. Basically, so think of getting like direct every patient. Direct is toxic. It can cause arrhythmia, it can cause PSP. Adverse events are the percentage of adverse events if you give direct will become much more than anything. So first, we should go with them. If it do not work, then you do them. That is one of the main, like why should we get thyroid in everyone? For supplementation, we use where the use of say medication outweighs risk. Secondly, as it says that it is not effective on the patient. Even in refractory depression also many times it is that also is not that it is like the role is to just keep the TSH as low as possible without increasing TC. Dr. Vishri? Okay, interesting. What is some of comments? First of all, the topic, I think that in the past 15, 20 years, we have seen the shift from even residents were say paying more attention to the psychological theories of depression, still utilizing in therapies, and there's a flood of non-pharmaceutical intervention. Now the shift is total towards the motor biologicals, and similarly you have interventions also. There are focus on the biological aspect, for example, the stimulation, brain stimulation techniques. So they're very important. I think this was the best presentation that you made in your as a very good, very nice, very good. You can say slides were very good, same format, easy to understand, and your
presentation.
I think I agreed, very well presented. The way he started with the overview, each and every subsections he gave, then he summarized the points at the end of each subsections, and all those summaries were subsequently discussed in take-home message points. The slides are very clean. He was speaking in prompt also in between. The graphics he used to explain the second messenger system. So that is Dr. Sarthak, I would say, is an example for everyone that everyone learns and you have to set your bar higher every time you present. So I can see for the first time recognition in him.
Yes,
So I
like
think
you can say that he's understood the topic and
yes, very, I think, very well presented, fulfilling presentation. Thank you.